Good afternoon, everybody. I think everybody is tired, like me, when I did the case. This is, by the way, my name is A Almorraweh. I'm working in SKSH, Ras Al Khaimah, which are our option when the patient shut down in the Cath lab. This is a young patient. He's 43-year-old male. He has a risk factor only, an active smoker. He has recent myocardial infarction 2 weeks before, which primary PCI done to him in another center. They put 2 stents in the LAD and 1 stent in the diagonal. And at that admission, he was diagnosed as hyperthrombocytosis. And then he has another chest pain and show up in the referral hospital with acute chest pain, and this is his ECG. ECG shows reinfarction. I don't know what this is. Anyway, this is the initial angiogram. Patient at that time, he was stable. Blood pressure is fine, lactate is fine, heart rate is fine, autosaturation. So there is acute stent thrombosis in the middle of the LAD. And this is the result of the wire. After the wiring, you see there is a thrombus inside. So what I did that, firstly, I just did NC balloon 3020. Just to improve the flow. And this is the result of the NC balloon. The flow is restored well. Usually our practice, when the patient has acute stent thrombosis or instant restenosis, we did an IVUS just to understand what is the etiology, why this patient has this thrombosis, and to prevent the recurrence as well. So I did an IVUS, and after the IVUS, I find mild malapposition. So I just adjust the stent by NC balloon 3515. I just want to back here. I will just want to show you that there is some first diagonal, ramus intermediate, circumflex with 2 branch. And after the NC balloon, you see, not anymore. All of them, they gone. So I take another view just to understand this is dissection, this is thrombosis. Patient start to shut down, blood pressure is down, he start to agitate on the table, and he developed shock. We start the inotropic. So first thing I did it actually is just rewiring the circumflex and put a stent just to restore the flow. So I put a stent from the left main to the LAD, but actually now the flow is decreasing even in the LAD territory and diagonal. And the patient now is in impending shock and deep shock. So the next move is just to insert the impella by right femoral approach, just to avoid the arrest. And the next movement was to do thrombus aspiration. So I did thrombus aspiration twice, and this is the flow after the thrombus aspiration. There is a large thrombus load, diagonal is still gone. And then I did the NC balloon 2020 in the circumflex to restore the flow in the circumflex, and I did two-step kissing in the distal left main. And this is the initial the angiogram. We find there is thrombosis or maybe dissection in the left circumflex. It's not clear at this point. Did NC balloon put by 4.58, and this is, let's see the final result or the primary result after the put. Flow in the diagonal, I did ballooning in the diagonal, I didn't record it, and the flow in the diagonal is restored, and there is thrombus there. So I did an IVUS just to be sure that the stent in the left main is fine and everything is well. And then I did put in by NC balloon 4.58, and this is the final result. Patient somehow becomes stable, blood pressure is acceptable. By the end of the procedure, lactate was 4, bedside echo is ejection fraction is 30. I did the RCA injection, which luckily was fine, insert swan gans, and check the distal perfusion of the femoral artery, just to be sure that no need to do any distal perfusion. The patient improved well, moved to the ICU, and on day 3, all the parameter was fine, and I decided to remove the impella. Before removing the impella, I was curious about the progression of the thrombus, how's the patient, how's the coronary artery, and we find there is still residual thrombosis, especially in the bifurcation and the middle of the LAD stent. Circumflex is fine, ramus intermediates come back, We remove the impella and we decide to have another relook for the patient after 7 days. So on day 7, I brought him back and I checked the coronary artery again. And just to be sure that everything is fine, the patient has already 2 infarction. So we find there is still residual thrombosis at the bifurcation. I didn't do IVUS because I already did the IVUS in the previous, before finishing the procedure. So everything is fine, all the stent, but I try to overcome the bifurcation thrombus there. I did two-step kissing balloon. And this is the final result. Patient did well, improved well. He discharged on day 10. Considering the thrombocytosis, I put him on the triple therapy for 1 month. Ejection fraction at discharge was 45. And he did follow up at, after 1 month, 3 months, and 6 months. Even he called me 2 weeks before this conference. He was fine. He did echocardiography in another center, which is ejection fraction is 50%. Follow-up lab test shows that the platelet decreased significantly. We put him, discharge him on hydroxyurea therapy, and follow up with the hematology team. So what can I learn from this case? That when the patient is really suddenly complicated and start to shut down in the Cath lab and in impending cardiac arrest, maybe the Impella device can be the fast and effective mechanical support, leading the patient to more stable condition. Don't underestimate the essential thrombocytosis. This patient is discharged from the previous center without any effective treatment, maybe the trigger of his instant stented thrombosis. And luckily, this patient, the team acting very fast, and we avoid even the intubation. And thank you very much.